Hello and thank you so much for joining us today for the webinar Simple, Predictable Everyday Endodontics. We would like to thank Dr. Jure Poglajen for being with us today and our sponsor for making this lecture possible. Please take note of any questions and comments you have during the lecture as they will be addressed by the doctor at the end of the presentation. Without any further delay, please help me welcome the expert himself, Jure Poglajen.
Hi, a very early good morning Tokyo, good evening Stockholm, and good day to New York. My name is Jure Poglajen and this is Slovenia Calling. Today we're going to talk about simple, predictable, everyday endodontics. But let me first just tell you where I'm coming from. This is Slovenia, a rather small Middle European country, which is not only the homeland of American First Lady Mrs. Melania Trump, but also a land of other great natural and cultural beauties. Its capital is Ljubljana, and the symbol of the town, of the city, is the green dragon. Ljubljana is ready for Christmas and New Year. As you can see, those are the three bridges and Prešeren Square already nicely decorated. Ljubljana, I don't know if you knew that, but Ljubljana in Slovenian actually, or in English actually, means the beloved one. Through the city center flows the lovely river of Ljubljanica. I was born here, raised and educated. I passed 6-year program at the medical faculty of Ljubljana for the dental medicine. After my studies, I moved back to our old family town called Brežice, which actually means Little Hills. This is the last very picturesque Slovenian town before a Croatian border, where it has its own water tower and ancient castle, where you can admire famous frescoes in Knight's Hall. And the replica of those you can find behind me and in our dental clinic. And this is my team. We have 3 doctors and 2 nurses, and we are family-based general dental practice, but specialized also in dental lasers. So, ladies and gentlemen, dear colleagues, let me first introduce you to show you the structure of this webinar. First, I'm going to present the tools and the materials we are using in our endo. In between, you'll see some clinical photos and videos. And at the end, there'll be clinical case showing endodontics. And of course, that will be followed by the questions. You can raise some questions, and I'll do my best to answer them. But first, dear colleagues, we have some basic demands. Since I'm a general practitioner, I'll do all the basic general dental work, and it has to be, because it's an everyday work, it has to be as easy as possible. Because I want to treat the majority of my cases with success without having to refer them to specialists. I need special tools for that. I want to spend as little time as possible, but still be very efficient. Our aim is to have a low biological cost, which actually means that we're preserving natural tissues. In plain language, it would mean we are adding, not taking. We have to have the aesthetical solutions since we are working in a very aesthetic area. At the end, we have to have satisfied patients and also satisfied us. Since I'm a person of more pictures and videos and less words, let me just first show you the list of the products we're going to talk about today. They're all the products of the Swedish company Directa Dental from Stockholm. We're going to start with Drydam, then the Practipal, and we're going to go through all the Calacept family products, and at the end also the irrigation needles. But first, let's try with our, I'd like to say, our green dragon. This is Drydam. It's actually a rubber dam with a very, very easy application. It fits like a mask. It has a soft coating for more comfort. I usually use it for safe amalgam removal. Of course, if possible, I use it for composite and glasionomer fillings, for bleaching, and of course, for today, we're going to use it in endodontics. So this is the back side of Drydam. It has a soft coating, and you see the front side where we have to remove the central part, and then we have to make a hole. It all depends which teeth we want to isolate, and then we isolate them. We fixate the dry dam. I like to fixate it with a rubber wedge, but it's actually up to you what you use. You can use dental floss, you can use metal clamps if you want. And this is how it looks all ready for the procedure. This is one of our nurses, Tatiana. And here I'm showing you the video, how to place a dry dam for the lower first molar. We're going to see later as well. So number 3-6. I usually need the help of my nurse. I can do it myself, but it's much easier. And then we fixate the dry dam behind the earlobes, so there's no need for any facial arch. Very easy and quite quick. So now we are ready. And we got to our second product. It's a Practipal. It's actually a system of trays with birth stands, file stands, consumables, and accessories. And as I like to say, it builds like Lego parts. It has 9 colors, so it's color coded. The cleaning and disinfection process gets really optimized if you use this system. And every clinic can make its own set. For example, we made our all endo, perio, and restorative. We're going to show you the endo and the restorative ones. So this is our restorative set. As you can see, I have the basic instruments there. I usually need that at every restorative procedures. There is also a burr stand where actually my nurse puts my usual selection of burrs. And there's a container for the disposable material. And this is our endo set. We're going to show later in our endo cases as well. So it's actually has 2 parts. One is similar to our restorative, but there's a second one where we have our file stand and endo set. And this is how it looks when it's sterile and ready to use. And we like to open that in front of our patients. I must tell you that the patients really appreciate that. They see that everything is clean and sterile just for them. So, dear colleagues, I think we are ready for some endodontics. So this is also you can see on the photo our setup. I use a microscope camera with a 60 times magnification. Of course, I use Practipal. There is also some space for apex locator, and of course, I use, you can see here, the dry dam already in place. So during my 6-year education at the medical faculty of Ljubljana, I remembered very important 3 steps of endodontics, 3 pillars of endodontics, we used to say. So one is, of course, you have to make a cavity access, which should be large enough to access access our canal. And then we have to perform root canal preparation and disinfection. We're going to talk about that a lot. And of course, we have to provide a proper obturations, which is also very important for a successful endodontic treatment. So first, let's see about root canal preparation and disinfection. The question always is how do we remove all the necrotic and infected pulp tissue? Of course, we have to do it with mechanical instrumentation, but of course, this is not enough. We know that. So we need to use chemical irrigation, intracanal medications between sessions, and I use myself as well laser irradiation. So let's talk about chemical irrigation. So of course, as in every material and every procedures in dentistry, we have to have some demands for as well here for endo irrigants. I just named a few of them, and first of all, it has to be cheap. It has to have an ability to remove organic tissues, and it has to have an ability to remove anorganic smear layer as well. Not, of course, we have to mention antibiotic activity. It should be non-toxic. It has to have solution stability. It has to have a prolonged antimicrobial activity after rinsing, and ability to disinfect dentin and its tubules. it has to have it has to cause no discoloration if possible, no effect on dentin physical properties, no effect on filling materials, lubrication for canal instrumentation, and has to be simple to use. They're very harsh demands, and so far none of the irrigants can fulfill all of them. That's why we're using combinations. So chemical irrigants can be divided into three groups. The first group is tissue dissolving agents. Actually, it's only one. It's sodium hypochlorite. The second group is antimicrobial agents. Sodium hypochlorite is accompanied by chlorhexidine here. And we have the third group, which is chelating agents. We are using EDTA, but you can use some others like citric acid. And there's actually a fourth group as well, which are the combinations of all of them already prepared. In all of the endo procedures, especially when we use irrigants, we have to follow special precautions. In our clinic, we always tend, if possible, we are using rubber dam. We are using irrigation needles with side openings, double side vents. That's why we are preventing the transapical irrigation. We're using Lurlock syringes for irrigation. We are using protective glass for all the team, and of course the patient as well. And we have to stop at 2 millimeters before the apex for the same reason, not to cause transapical irrigation. And then we have our first irrigant. It's sodium hypochlorite. It's today's basic contemporary irrigant. It's actually the only one with two important properties. The first one is it's dissolving the organic part of smear layer, and the second one is very good antimicrobial action. It has a pH of 11, so it's very alkaline. In literature, you can find that the concentration as an irrigant, it's used from 0.5 till 6%. And the indications in the dental office are actually two. First one is the cavity and working field disinfection. We use 1.5%. I usually use for cavity disinfection when I work with glasionomers. Because when I work with composites, it actually it diminishes the bond between the composite and dentin. And as an endo irrigant, one can use it from 1 to 6%. But I have to stress out here that when it's still foaming, we'll see on the picture later, it means it's still active and organic material is still present. It still works, so let it be for a while. We can also, by increasing the temperature, we can increase the effectiveness of the irrigant. This can also be done with laser. And of course, we can use ultrasound agitation or irrigation, and that will also enhance the action abilities of the effectiveness of our sodium hypochlorite. But sodium hypochlorite unfortunately has quite a few disadvantages as well. It's toxic, and of course the higher the concentration, the higher the toxicity. It has a very bad taste and smell of chlorine. For the taste, we have the solution. We are using the rubber dam. That's very, very effective. It has a disability of removing anorganic smear layers. So we have to use, what we see later, EDTA for this reason. And as I mentioned before, it diminishes the resin-dentin bond. So if we're putting the permanent composite bond afterwards, we can compromise that bond. Sodium hypochlorite is also a strong oxidizer. So oxidation reactions are corrosive. So we have to use the rubber dam and special needles to avoid a majority of these disadvantages. So in this video, I'm showing you the tooth 1-2. The diagnosis was pulp necrosis and symptomatic peri and paraapical periodontitis. And we are using double-sided vented needle, Lurlock syringe, and sodium hypochlorite, this time 3%. On the next video, I'm going to show you the 236 that we saw before as well, also showing the irrigation with sodium hypochlorite, again 3%. It's the same procedure, just a different tooth. The diagnosis is a little bit different here. It was pulp necrosis with asymptomatic periapical periodontitis that we saw on X-ray. And we'll move forward. Now we came to our second irrigant, which is chlorhexidine. It's antiseptic. In literature, you can find the data that is used from 0.5 to 2% in gel or solution. The gel is actually a little bit more effective than the solution. It has a prolonged action. It bonds to a hydroxyapatite and it precipitates in layer, and it works as a depot. It works also against E. fecalis, which could be a problem, and it actually enhances the resin-dentin bond. There are some disadvantages, of course. Does not dissolve the organic smear layer. That's why, dear colleagues, we have to use still sodium hypochlorite before that. But we should not mix it with it. If we mix chlorhexidine with sodium hypochlorite, we'll get a red precipitate, and this one could be toxic. That's why we always use saline in between all irrigants, not to affect one on another. And we are at our third irrigant, which is EDTA. It actually removes anorganic smear layer. It is used in 17% concentration. I tend to always use it after sodium hypochlorite. Of course, there is saline in between. The effect is short-lasting and self-limiting. We use separate with sodium hypochlorite because it diminishes its power. With chlorhexidine, we get quite harmless precipitate, but even though we like to avoid that too, so we do use saline in between. And as I promised before, we're going to talk about the irrigation needles. This one of Calacept, it's Lurlock. It has a Lurlock hub. It's double-side vented. It's bendable, stainless, and it comes in two different sizes, and they're very, very handy and very safe. As I mentioned before, there's a double opening, which actually produces this swirl effect in the canal. But still, we have to be careful not to reach the canal till the end. So we have to have this 2 millimeters safe distance before the apex. Let's talk a little bit about calcium hydroxide. It has a pH of 12.5, which is very alkaline. It's actually a very old medicine. In 1920s, it was introduced as the hard tissue induction and apexification, but only later in mid-80s, it was introduced as the intracanal antibacterial dressing. It's a white powder with no smell. It's poorly soluble in water, and we all know it. But let's, dear colleagues, see what are actually the indications for applying calcium, for using calcium hydroxide in dental medicine. There are many. First of all, is definitely vital pulp capping, and second one is intracanal dressing. The others are apexification, root fracture, root perforation, and root resorption. But I think nowadays we have better materials on market like MTA and biodentin. So for those the last four one, I'm not using calcium hydroxide anymore. But let's go to vital pulp capping. Um, I had some fun, so I had a look on Wikipedia what actually says about pulp capping. It says it's a technique used in dental restorations to prevent the dental pulp from dying after being exposed or nearly exposed during cavity preparation. So let's see. Let's have a look about the case when it's nearly exposed. So we have indirect two-step cavity preparation for deep caries, nearly exposed pulp. So, dear colleagues, we have to, of course, remove the soft and infected dentin. Then we leave the uninfected dentin close to the pulp. We cover it with calcium hydroxide, and myself, I cover it with glasionomer. And we leave it there for 6 months. And then after that, we open it and remove the rest of the carious dentin. Of course, we have to ask ourselves what is the mechanism of this treatment. It's actually the dentin permeability is decreased from both sides. From the coronal side is protein denaturation and coagulation, and that's why the dental tubulus close. And from the pulpal side, the stimulation of secondary dentin formation, and of course, in both of them, antibacterial effect on surface. But what about in case when we have direct capping or vital amputation? We actually exposed our vital pulp. Um, we could be we could have the diagnosis of reversible pulpitis, but not more severe than that. What we do with our calcium hydroxide is that we're causing 1 millimeter surface necrosis, which actually gives bioactive signals for pulp repair, and also due to a very alkaline pH. The indications for direct capping is non-infected dentin. So let's see. Let's for example, if we are making a preparation for a veneer and we accidentally bumped into pulp, and we have to have no pain in history, of course. After that, we have to do the hermetic filling, and we have to have a recall and constant monitoring what is happening with our pulp, whether our treatment is successful or not. And of course, calcium hydroxide is widely used for intracanal medication or intracanal dressing in between our endodontic sessions. Especially when we have periapical lesion treatment, what we can of course see on our X-rays. What it does, it disinfects canal and our dental tubules. But we have to know, dear colleagues, that the effectiveness it depends on chemomechanical cleaning, as we said before, but also of the initial bacterial flora. So it's not all the same if the tooth was the canal was open for quite a long period of time or not. Of course, the antibacterial action is due to high pH, but we have to mention this except for E. faecalis and Candida. It is still the most effective intracanal dressing and the most widely used. And as you will see later, we're using FlexiTip for intracanal application without lentillo spiral. So we are trying to avoid transapical transportation of our calcium hydroxide. In this video, you'll see the FlexiTip. We're going into the canal. The canal was, of course, before that dried up. And we are applying our Calacept plus into the canal up to the opening, and then we're going to put some cotton pellet, cotton pellet, and we are going to temporarily obturate the canal. The same we did to our 236 from the previous case. Here, of course, we have three canals. or in this case, maybe even 4 canals. And we are applying with a syringe, with a Lurlock syringe and our flexi tip, the, the medicine into the canal. But if we just have a look at the composition of Calcipt Plus, it's 41% is calcium hydroxide, the rest is barium sulfate and sterile saline, of course. As we mentioned before, it's very alkaline, it's 12.4 pH. And this is the original packaging. As you see, it comes in syringes. There are quite many advantages. It's definitely time saving, so there is no lentil spiral. There is optimal ion release, much better than from the other products. They have the product is setting. This one is pure. It has a long-lasting effect, but I usually leave it for a week. It has, as we saw before, flexi needle application. It's precise and deep application, so the canal is totally filled with the medicine. There are no gaps. There are no air bubbles. It's pre-filled and it's airtight syringe, which actually comes very handy because we all know when we expose calcium hydroxide to air and to CO2, we get calcium carbonate. There's no drying out because of that. It has a very smooth consistency, which actually allows it to flow smoothly through our flexi tip. Yeah, no calcium carbonate. And the flexi tip itself, on one side there's a Lurlock syringe, and the other side there's a root canal, and it flows really smoothly through all the way. And then we came to dental lasers. In our dental clinic, we use two types of lasers. One is diode 940 nanometers, and the other is erbium chromium YSGG 2780 nanometers. We're using in almost all our procedures, and especially in endo. So, of course, we always ask ourselves at new things, why should we use that? And there are some good reasons why. First of all, it's modern dentistry. Definitely, soon every dental surgery would have at least one type of laser, and the patients really ask for it. So, do you have a laser? If you have a laser, you're considered to be a modern dentist. It's majority of the cases it's painless, but it should not be advertised as a painless dentistry because it's not always the case. We should not promise that to the patients. We can promise it will the pain will be much reduced, or in some cases there will be no pain. We always have, because of the laser irradiation, you always have sterile area, which is far more hygienic. In a majority of the cases, we don't even have to touch, so we're doing in no touch mode to our tissues. Sometimes we have no shot, no pain, and no drill. But in majority of the cases, we still need to use the drill as well. As a side effect, or I would say as a bonus, we always get biostimulation. So our tissues, our natural tissues, get healed much quicker. We also can modulate the pain. I'm using the diode, of course, for bleaching, and I'm always using the diode or both in endodontics. This is the video showing the tooth 112 from before. After instrumentation, of course, there is sodium hypochlorite in the canal, and we go in the canal with our laser. 4 times in and out. The velocity is somewhere in the area of 2 millimeters per second. Of course, we're using dry dam, and this is our 3/6, the same procedures, but here 3 or 4 canals. And the third pillar of endodontics is obturation. We all know the endo in endocorneal seal is very important. I mean, it's useless to do a very, very good endodontics, but if we don't make a very good obturation, it's all in vain. That's why I'm presenting Calacept Temp. It's a temporary filling material. The composition is zinc oxide, glycerin, and sulfate hemihydride. The advantages would be it's, of course, self-curing in the cavity. It has a high adhesion to dentin with a very good marginal seal. And high abrasive resistance. There is no pulp and gingiva irritation, and it has a very simple application and removal. I used to I'm used to I used to use that between our session, but between endodontic sessions. But sometimes I use glasionomer as well. So this is the video showing how it's very easy to apply that. We're applying with spatula, and we're trying to adapt the material. Beneath that there is a cotton pallet, and of course intracanal medication, calcium hydroxide applied with a flexi tip. Okay. So there's one more thing. Of course, around the globe, there are many different schools, dear colleagues, and many different ways. And there is not only one correct way. This is our way. We are showing, and there are many ways to reach our common goal, which is to have a successful endodontics. And I'm going to present our endo protocol. First, a very careful examination of the case is made, patient's history is taken, and X-ray accessed for every endodontics, of course. Then we have to establish the correct diagnosis. And the prognosis, of course, also explained to the patients. My experience is telling me the patients are really, they really appreciate if they are properly explained what condition they have and what procedure they're going to have with their teeth. So the explanation role of the dentist is as important as a therapeutical one. So we have to explain what is going to be done. And then, of course, we apply the local anesthesia if it's needed. Then, of course, we always tend to use the rubber dam. Then we disinfect our working field with 1.5 sodium hypochlorite. We access the cavity with a sterile burr. Then we do the manual endo instruments to establish working length and manual instrumentation in ISO 15 minimal. Then we use the mechanical nickel titanium instrumentation with endophiles. My golden standard is ISO 40 and taper 0406. But of course, here there are still many theories and practices schools that teach even less, ISO 25, 30, or even less. And then we irrigate with sodium hypochlorite, EDTA, and saline in between. And of course, when we do all the canal instrumentation, then we use sodium hypochlorite with irrigation needle and laser irradiation with 940 nanometer. In between, there's always a saline irrigation. Then comes EDTA and chlorhexidine in very tough cases. Of course, then we are drying up the canal with the paper points, and we apply calcium hydroxide dressing with our flexi tips with Calacept Plus. And of course, the obturation, we're sealing the canal for at least 7 days. We can repeat this session many times until we have fulfilled the conditions for permanent canal obturation. This is the final session. We always rinse the calcium hydroxide with sodium hypochlorite. Then we radiate with the laser, of course, the diode. At the end, we have to irrigate with saline. And final checkup of the working length. We are drying up canal with the paper points. We apply the sealer and the root canal filling, and we are sealing the cavity with temporary filling or permanent filling. I prefer permanent filling, so that's why we can really ensure that the tightness of our obturation. Of course, we do the X-ray immediately after, and we are following up this root canal treatment every 6 months. Now we came to our clinical case. Uh, this lovely lady, her name is Mania. She is 27. This is one of my recent cases. She comes from Sjenica, which is right now the most famous town in Slovenia. As I mentioned before, is the hometown of Melania Trump. We had to treat two teeth, two central upper incisors. So the diagnosis for one is previous unsuccessful endo treatment and asymptomatic chronic periapical periodontitis. And for the second one, 2-1, we have asymptomatic pulp necrosis. We tried electrical test and X-ray. They were both positive for necrosis. And there's also asymptomatic chronic periapical periodontitis. So tooth 1 has had the remainings of calcium, old calcium hydroxide dressing. And in both teeth, the working length was 18 millimeters. We instrumented with nickel titanium instrumentation with bi-race sequence till ISO 40. And because we did the disinfection and irrigation with irrigants and diode laser. This is the OPG of that patient. And this is the local X-ray where we can see the old calcium hydroxide remains, and our working length is 18 millimeters. So first we're going to place the rubber dam. As I said before, I always get the help of my lovely assistant Nina. It's much easier, it's quicker, and then we're going to fixate it behind the earlobes. Yeah, and we are ready for procedure. We're putting in the suction. Yeah. After that, of course, we have to disinfect our working field with 1.5 sodium hypochlorite. After that, we have the coronal access with a sterile burr. And then, of course, we did the manual endo instruments to establish the working length, as in protocol. Manual instrumentation till ISO 15, and then we use the nickel titanium instrumentation till ISO minimal 40. After that, oh yes, in between we have to set the endo instruments to our working length, where the endometer actually on the already set on our tray, Practipal. And then we did the sodium hypochlorite irrigation with our Lurlock syringes and double vented needles in both canals, of course, removing the organic smear layer. And this is the same procedure from a little bit further away. Sodium hypochlorite 3%. You can also see the practical endo where we have space for our apex locator, which comes very handy. Then after that, oh, that's what I mentioned before. When we see foaming of sodium hypochlorite, it means it still works. It's working. So we should let it be till the foam disappears. And the hypochlorite actually works for not more than 2 minutes, and then we have to replace it. The laser irradiation with 914 nanometers, 1.2 watts, continuous wave. We go into the canal and we go 4 times in and out with a velocity of 2 millimeters per second. And then we're moving to saline irrigation in between, because after that we're going to use EDTA, and we don't want to mix sodium hypochlorite with EDTA. I can see Calacept EDTA in the bottle, and irrigation in our 2 canals. And that's why how we are removing the anorganic smear layer and opening up the dentin tubules. Of course, in between we use the saline again, and now we're using chlorhexidine, because this was this canal in tooth 1-1. It was open or partially open for a longer period of time, so we are quite sure there will be a problem with E. fecalis and Candida. That's why we are using all the weapons we have at our disposal. Here I would like to show you how we are using the flexi tips and how we are assembling the flexi tip and syringe. The flexi tip has to be sterilized because there is no point in putting non-sterile flexi tip on our sterile calcium hydroxide, and that's how it is applied into the canal. And this is a close-up. Flexi tip into the canal, in the canal, and up to the opening. And then we're going to put a cotton pellet and Calacept temp to make a temporary obturation. So this is immediately after applying calcium hydroxide, which is now in the canals. The radiopathy is similar to dentin, so it cannot be mistaken for a root canal filling. So if this lady goes to a different dentist, he or she would know this is not the canal filling; it's the intercanal medication. And we can also see the cotton pellet, looks like an empty space, of course, and Calacept temp as a temporary obturation material. As this lady was about to get married on a very exotic place in Mauritius, actually, we had two more sessions on the 14th and the 21st, so 1 week 1 week difference. And I did not decide to make a permanent root canal filling, but we changed our calcium hydroxide dressings. And we did, of course, the laser irradiations with 940 nanometers. And at the end, before her trip, we sealed the canal with a glasionomer, not with Calacept temp. And we wish her all the best, and hopefully the groom would say I do. So hvala za vašu pozornost. Thank you for your attention. That will be all from me. Of course, if you have any questions, I'll do my best to answer them. Okay, let's start with Wael Al-Hassani, Al-Jaziri. Did you use H2O2 for irrigation? No. Actually, our doctrine prohibits that. We don't tend to use that because there's a great risk of emphysema. So we don't use that for irrigation. His second question would be, did you use light cure calcium hydroxide for capping or fresh calcium? We always use fresh calcium. Calacept Plus is always pure flesh, non-setting material. But of course, in this, you can use MTA or biodentin or something else as well. But traditionally, it's used non-setting calcium hydroxide. Somia Rashid, what's the purpose of using laser inside canal with sodium hypochlorite? The canal, Actually, the sodium hypochlorite is being heated up by laser as well. So this is one of the favorable side effects. That's why I'm using it together with laser. Milena Ivanova, did you use citric acid for irrigation? No, so far I haven't. So I have unfortunately no experience on this field. Vadia, um, can we use sodium hypochlorite and EDTA together? Well, we can actually, but EDTA diminishes the power of sodium hypochlorite. So I don't like to mix that. I always use the tampon zone actually is saline, so I don't recommend that. But nothing really harmful would happen if you mix that together. But there are some data and literature that you can cause intracanal resorption if you use, because the combination of sodium hypochlorite and EDTA could be too aggressive. There's some data about it. Somaya Rashid, 1.5 sodium hypochlorite is the full concentration, or it is diluted with saline? Because what we use is 5.25 full concentration. 1.5 is used just for cavity disinfection and working field disinfection. I usually use 3% for intracanal irrigant. Vadia, can we use paper points dipped in calcium hydroxide paste as an intracanal medicament? Well, I cannot answer that. I've never used that. I like to use pure material. So you have to ask someone who has more experience about that. Joanna Mihaila, good evening. Most of the endodontic specialists, okay, all the names, use sodium hypochlorite with concentrations 5%. Why 1.5? As I said before, 1.5 it's not for endo irrigation. 1.5 it's for disinfection of our working field and cavity before putting a filling like glasionomer. Any more questions? Why lower than 5%? Oh, well, if you use 3% and if you heat it up with laser or let's say ultrasound, or you preheat it before with a special syringes, is according to some data in literature as effective as 5%. So there is no need for higher concentration, according to my opinion. But Valentin Petrov is calcium hydroxide points any good? As I said before, I have no experience in that. You're welcome, Joanna. Somia Rashid, thank you for our presentation and your time. Okay, so greetings from here. Greetings from Slovenia. Any more questions? So I guess if not, thank you very much for attending. Thanks to the sponsor, and I hope to see you soon. Goodbye.
We would like to thank our speaker for sharing his knowledge and expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care, and goodbye.